All right, welcome to Leading Rural Healthcare, the podcast where we talk with leaders shaping the future of healthcare in rural communities. I'm your host, Brendan Hurley, and today's episode takes a national view of the issues affecting rural hospitals and the communities they serve. Joining us is Alan Morgan, the Chief Executive Officer of the National Rural Health Association, whose mission is to provide leadership on rural health issues through advocacy, communications, education, and research. Alan has more than 35 years of experience in health policy at the state and federal levels and is widely recognized as one of the nation's leading experts on rural health policy. In fact, he's been named one of the 100 most influential people in healthcare by Modern Healthcare magazine. Alan has served as a contributing author for the publications The Handbook of Rural Aging, Rural Populations and Health, and the publication Policy and Politics in Nursing and Healthcare. In addition, his health policy articles have been published in the American Journal of Clinical Medicine, the Journal of Rural Health, the Journal of Cardiovascular Management, and in Laboratory Medicine. Since joining the National Rural Health Association in 2001, he's helped lead advocacy and policy efforts on everything from rural hospital sustainability and workforce to payment policy and access to care. So there's a lot there. Alan, welcome to the Leading Rural Healthcare podcast. I'm really excited to talk with you today.
Hey, Brendan, I'm excited to be here and talk about my favorite topic, which is rural health.
Fantastic. Well, let's open up with you just kind of giving our listeners a little bit about yourself and maybe the National Rural Health Association and its role in supporting rural healthcare.
Oh, sure, that's a good place to start. So, Brendan, I'm originally from a small town north of the state capital of Topeka in Kansas, Holton, Kansas. Right after college, I went to work for former Kansas Governor Mike Hayden, and then packed up my bags, went to D.C., worked for former Congressman Dick Nichols. I spent about a decade lobbying for healthcare, and but for the last 25 years, I've been with the National Rural Health Association. And for your listeners, if you care about rural America and rural health, there's a home for you in the NRHA. And you alluded to this. What we do is we identify best practices for delivering high quality healthcare. We share those with our members in conferences, publications, webinars, and we hope for replication. So that way we can expand the best of the best. And so I love my job, Brendan, because I get to see the innovative approaches to healthcare delivery on a daily basis.
Yeah, I love it. Well, we'll get there, but share with me, some of that innovation that you're seeing that's real time, that's maybe new, cutting edge in rural health. Now, you might have a long list to pull from, but I'd love to kind of hear your perspective on maybe even something recently that's hit your radar as something you might want to share with the listeners.
Okay, I got to tell you, I love how this is starting off because usually I have to drag myself through about 15 minutes of saying everything that's lacking in rural health. I really appreciate the fact that we're going straight to the innovation component of it. New approaches towards workforce and how do we grow our own? How do we keep kids in our communities? I just think that is a proven winner, and a lot of communities and hospitals are taking that approach right now. Number one. Number two, boy, technology. Gosh, that's all you're hearing at the federal level. Dr. Oz, the Centers for Medicare and Medicaid administrator, he can't stop talking about technology. Neither can Senator Kennedy. It's not going to be the end-all salvation, but it sure is cool to see how these things are implemented in small facilities. So I like that as well too. I really like this focus on population health that we're seeing in rural towns. And how do we keep our community healthy and out of the hospital in the first place? So those are the top three that I enjoy seeing from innovative approaches. Boy, we can spend a whole podcast talking about that.
Yeah. Well, give me briefly. I love the topic, and it wouldn't be the first time it's come up on this podcast. The Grow Your Own initiative. There's a lot of rural health facilities, rural hospitals engaging with their local school districts, developing these programs. But I am curious for our listeners, of the programs you see, what's most critical for success in those programs? Because we talk about, even in my role as a benefits consultant, total rewards consultant, recruitment, retention strategies with our clients, especially in the healthcare sector, bringing in top talent and the right talent can be tough. And so these grow your own programs can be extremely influential into the success of the and the perpetuity of the organization. So I'm curious what you're seeing out there, in terms of what's working, above all else.
Yeah, yeah, and let's be honest. A lot of our focus is how do we position facilities in rural towns to best sell themselves to the graduates. Whether and
Hmm.
let's not just talk just about clinical staff. I mean, we're talking administrative staff, we're talking about clerical, we're talking about housekeeping as well too. Here's the problem that really drives me nuts about this. We spend so much time. What are we going to do about rural America? How do we make it better? Not a darn thing. Let's don't do anything differently. Here's my point. 2019 Health Affairs identified that less than 5% of the nation's medical school incoming students come from a rural area. Less than 5%. How we do medical education in the United States is we take the best and the brightest upper income urban kids from New York City. We train them in New York City. They do the residencies in New York City, and they were dumbfounded that they don't want to move to Flush, Kansas. Who knew? I mean, this is
Yeah.
such a bad way to do this, and this is how we do it. And so when we talk about grow your own, it's really what I want to see is how do hospitals, it may have an old 1940s Hill Burton facility, it's too big. How do they convert part of that wing into an educational campus facility? How do they work with both local high schools and local community colleges to try to communicate, hey, there's a future for you in this town with your family. And it's a great future when it comes to healthcare.
Yeah. Well, I couldn't agree more. And it seems like we have to take a step back and understand the root causes, right?
Yeah.
Not just talk about the program itself, but why aren't we getting the candidates? And so, you talk about how technology's been. Let's stay on innovation a little while before we go anywhere else. But what are you seeing? You talk about technology. I want to give you a spot to maybe talk about what you're most excited about and what rural health leaders should be aware of and maybe even embracing.
Yeah. So for the last 30 years, we've been saying, hey, we need telehealth, we need telehealth, we
Mhm.
need telehealth. And well, lo and behold, we've got telehealth now in many cases. It's starting to expand slowly, slowly. The adoption is slow there. So what I enjoy is when you're using either telehealth or now artificial intelligence as a tool to help support current clinicians. It concerns me greatly when they talk about it as a replacement.
Right.
Now, when you have specialists where you're just never going to have the patient base or the financial backing to bring in a whole team of specialists who live and work 24/7 in these facilities, but utilizing telehealth come in, that's great. I love utilize what I'm seeing and hearing from my members of utilizing telehealth to free up their time through documentation. I think that's fantastic. A lot more studies on that that's happening going out there. And also as appropriate, using it just as a gut check on what you're seeing, and let me check on that, and just to be able to use that. I think that's great as well too. I also like the fact that they're using it in billing as well too now, because the insurance companies are using it
Yep.
for denial of claims and be able to make sure that they're coding correctly to be able to be reimbursed for the services. It's all about keeping those doors open on these facilities.
Yeah. So we know that large facilities have always had it's Goliath versus Goliath, right? But in rural health, it's the independent rural health system is it's a David versus Goliath when we talk about um, payer issues, right? In that realm. So, what are you seeing in terms of, is this helping rural health systems, the technology piece, the validation that they are submitting the right codes, et cetera? Is it bringing them up to parity or much closer to with their urban and larger system counterparts? And is this technology going to be a key in keeping them from having to partner, right? I mean, is it kind of one step closer to being able to stay autonomous?
Brendan, I just love the way you slid right into the topic of Medicare Advantage without out actually saying Medicare Advantage. That was good. Well done. Well done. So yeah, what I'm hopeful and what we're seeing is, and I was worried, are rural providers going to be able to have the staff to be able to vet the AI systems and implement the AI systems? What we're seeing is they're just being added on, to their EMS.
Yep.
We're seeing, and just your listeners are having that happen in their email, whether it's Outlook and where you're seeing Copilot. AI is like technology crabgrass. You don't have to fertilize it, it's happening. So to answer your question, yeah, it is just becoming part of the administrative processes in most of these facilities and the clinical processes. I love that. Technology has always been such a tough nut to crack from a rural perspective because, like you said, you just don't have an
Yep.
entire tech department. It's the CEO and CFO of a small hospital trying to decide what they should do. So I like how they're being built into the systems they already have.
Yeah. Well, you've spent more than, I mean, let's kind of take a step back just on the landscape side of things. You've spent more than 30 years working in rural health policy. Uh, when you take a step back and look at rural healthcare today, how would you describe the overall landscape and, maybe even compare that to what it looked like 5, 10 years ago?
Yeah, it's complex. It's always been today, it's a tough story to tell, an accurate story of what we're seeing in rural healthcare. And it's because these intense pressures that rural healthcare providers are seeing is forcing innovation and forcing some amazing creative approaches. And so you want to tell an accurate story. I don't think we're doing the story we need to get out there about the quality of care when it comes to primary care and general surgery. Whether you're looking at CMS data, Institute of Medicine data, state or federal data, you see rural clinicians and hospitals consistently providing as good or better quality when it comes to primary care and general surgery. Number one. But a lot of that is being based on these incredible financial pressures, workforce pressures, and all these are coming to bear. So as a result of that, it's a complex story. It's the best of times, it's the worst of times. If I have my preference, I want my family to go to a small hospital and a small clinician, small town clinician when it comes to primary care.
Why is that?
Just from the data, it's not surprising. I mean, one thing that Institute of Medicine has showed in the research is repetition leads towards best quality.
Yeah.
Repetition, utilizing best practices. And what we're seeing in these rural towns, one, they know their patients most often. They see them at the softball game and they see them eating
Right.
a chili dog. So they're not just patients. They're part of the community. A lot of medical errors in hospitals happen during the handoffs. And when you're having those nursing shifts, well, when you're shifting the nurses and they still know you as well too, that helps it as well too. So because of that, that's so important. Now, you're getting into a whole different discussion. If you're talking about invasive cardiovascular procedures, yeah, you want to get to a large urban facility most often for
Sure.
that. But just because of what they're seeing, their day-to-day work, doing it again and again, knowing the patients, knowing you, and having that sense of community and collaboration, it's just a really great. People don't realize the community assets that rural hospitals are.
Yeah. Well, you talk a lot about this federal data and data compilation. What do you think leaders should be most aware of? Like when I think of a rural health center, we've kind of already talked about, the leadership is wearing a number of different hats, right? And so we talk about data integrity and what's being ingested and then spat back out to the public that then subsequently ranks a hospital or ranks even certain clinicians within a hospital or gives it a star rating. What are you seeing leaders look at very keenly to try and improve those metrics, right? I mean, when I think again of a larger system, there's probably teams who are looking at that and saying, let's give ourselves a self-diagnosis and understand where we can improve and making that part of a systematic process. But when it's such a few, again, the data is probably a smaller subset, right? There may be fewer key performance indicators that they decide to zero in on. But I don't want to make those statements. What are you seeing in rural health and how they're evaluating that data and making the best informed decisions as organizations.
Yeah, for most rural hospitals in most states, they're working with their peers throughout the state, most often with the State Office of Rural Health,
Yep.
as part of the Medicare Rural Hospital Flexibility Program. And so most of them already are sharing and collaborating when it comes to quality data and being able to benchmark among each other. So, Brendan, I mentioned the top end of this. We do these educational conferences, and probably not surprising, the people that I see at my conferences are not like my general membership. And if you're going to a conference, you're a top performer. And let's be honest with you. I get out into these rural hospitals across the US over the last 30 years. And unfortunately, so many times when I talk with CEOs, I'm like, hey, I haven't seen you at my conference. Like, well, you don't understand, Alan. I've got these challenges. I got to find, I can't get out of this. And I can't tell you how many times, 6 months, a year later, they're out of a job. And it is a unfortunate situation where we're seeing these successes is where they are working with their peers on the state level, where they are getting engaged at the national level, where they're trading these best practices and being able to replicate them in their facilities.
Yeah. Gosh, that is such a common theme with some of the such high quality leaders I've had on this podcast and on this discussion so forth or so far. Almost every single one of them is engaged in that way and has talked about it even unpromptedly, right? I mean, there whether it be with the Missouri Hospital Association, who's our presenting sponsor, at the federal level, right? I had a chief information medical officer at a rural access hospital, who's, by the way, one of the, I believe, top 100 rural access hospitals by ranked by National Rural Health Association. He spent time at Capitol Hill and understanding what they need to do to be relevant in the next 10 years. And so it's kind of cool to hear you say that and then get that validation from boots on the ground here in Missouri.
Yeah, I'm a huge fan of the Missouri Hospital Association. They bring their membership out to DC to lobby. I get a chance to talk with them while they're out here. My team gets a chance to talk with them. Gosh, this is going back 20 years. I mean, they've been a national leader. And so fortunate to have that organization there in Missouri.
Yeah. Well, when we talk about data, we can't neglect thinking about Heidi, right? And some of the cool programs that are put forth by the Missouri Hospital Association for their members. So, kind of going back to policymakers, I mean, what do you think, you know, is most often misunderstood about rural healthcare, and how should rural leaders communicate those realities more effectively? I know that's what you guys do on a daily basis.
Yeah, wow. Okay, now you touched a pain point right there, didn't you? So, what really frustrates me at the federal level is oftentimes and I mentioned at the very beginning, they view rural as just a small version of urban, and it's not.
Mm.
It's a unique healthcare delivery environment. And number two, they think that the challenges that these rural hospitals are facing are because of two reasons, and they're not. Number one, they think, well, it's low volume. No, it's not low volume. And two, they think, well, it's bad management. It is absolutely not bad management. Brendan, since 2005, we've had more than 200 rural hospitals close across the U.S. The majority of these have closed in the southeast of the U.S. When you look at a national map, the majority have closed in the Southeast. Now, you cannot tell me that the Southeast has cornered the market on low volume and bad management. That doesn't have face validity. That makes no sense. It's happening because we've clustered people in these communities that have high health needs and the inability to pay. And you see that more often in the Southeast. You see that a lot in small towns in Missouri as well, too. In the United States, we love high quality healthcare. We just want someone else to pay for it. And so in the US, as a result of that, rural hospitals pick up the bill. You've got a clustering of these individuals that have high health needs, and it ends up being bad debt. And that is what closes these rural hospitals. It's not low volume, it's not bad management. And that's why you circle into this whole discussion on Medicaid.
Well, and again, you could talk about what's going on, the climate right now. I mean, is there anything that's giving you optimism? I mean, is there anything that's cutting through the noise in terms of those willing to listen about the problem you're outlining?
Oh yeah, it's the upcoming midterms. There's nothing like a federal election to clear the mind of policymakers in Washington, D.C. So the good news, what I do like, is included within the HR one, the one big beautiful bill last
Yep.
fall, was a $50 billion 5-year rural transformation fund. Now, this is not dedicated solely towards rural hospitals. We have called for the majority of this to be focused on rural hospitals because we're trying to keep those doors open. But this is a once in a generational opportunity to actually focus on transformation. How do we create a sustainable future for rural healthcare delivery? And so I think that there's a lot of focus in DC now on this. We talk so much about keeping the doors open in these facilities that we don't talk about fundamentally how do we
Changing.
change how we're delivering healthcare.
Right, right. It's not meant to be a crutch. We've talked
No,
about the
no.
Rural Health Transformation Program, and it's going to be administered differently, slightly at every state level, right? And so I've been more hyper focused on Missouri, but when you think about the program at the national level, do you want to give us a little more color around not only what's the problem it's trying to solve for, because we know it's kind of brought in after the one big beautiful bill, right? As some view as supplemental, but what's the problem it's trying to solve, and where do you think it's going to have legs?
Yeah, well, the problem it's trying to solve is every other year Congress passes a rural extenders bill or some sort of rural bill to try to keep the doors open on clinics, on hospitals, and maintain access for maternity care, behavioral health. And despite every 2 years of passing legislation, the life expectancy continues to decline in rural America. It just isn't working. It just isn't working. So the concept is, okay, let us actually provide this money to be able to think about what's an innovative approach to address rural healthcare in a sustainable manner for the long term. This is not to fill the gaps. It's not to keep the doors open. It's how do we get a rural hospital to collaboratively work with Meals on Wheels, the senior center, the school system to be able to address obesity, diabetes, hypertension? How do we empower patients? How we do so in such a manner that we can continue this and that we can arrest this decline of life expectancy.
Yeah.
So, what I'm hopeful we get out of this is some really creative approaches from workforce, from technology, from financing, from public health to be able to bend this curve back the other direction where we have longer life expectancies and we have a sustainable healthcare system.
Yeah. So many of the initiatives and how you'd roll them out are, in my mind, indicative of partnerships within that community, right? Things that happen outside of the hospital. And it kind of brings me back to a question and theme that, I've had with a lot of the guests, which is the value of independence versus a large system with a rural presence, and the conflicting, not the large system's fault, but the conflicting interests of what is our charter, what's our mission in this community, what is our, how are we going to serve this community, and comparing that to what might be uh, other initiatives from a larger system like shareholder concerns, et cetera. And so I guess coming around to the question, how valuable do you think independence is when we talk about the rural health transformation, uh, in being able to deliver on some of these foundational changes that need to happen?
Well, I think in my mind, at least, any small town, if you're in your small town, you want to make sure that the healthcare is reflective of the needs of that community and is delivering services that that community needs. Really, that's
Yep.
the fit to that. Um, and I have seen amazing examples of systems and for-profit systems, for that matter, who have been able to engage in local leaders and make sure that they check that box. That being said, I mean, I love independent hospitals. You have to. I mean, NRHA, that's the heart of
Yeah.
that's how we were created. These independent hospitals that have the service area and the service mix to be able to sustain it. And there is just so many examples of that being done successfully. But it's not always the case. And I've seen you've seen good cases and you see bad cases. I wish I could just say, oh, those are all terrible and those are all great. But at the end of the day,
Kills
it's
me.
how are you engaging the local community to make sure that the healthcare is responsive and reflective? Once you start removing decisions outside of the community and outside the state, you run that risk of making purely financial decisions. And that's where we run into problems.
Yeah. If you're sitting in the role of a CEO of a rural hospital, what steps are you trying to take, given what you've seen in the market in your field, uh, to engage and lean in best to the community's needs outside of needs assessments and things like that? I mean, what are you seeing pioneers, those that are at the front of innovation of making sure they're serving their communities really look at? And then, does that mean new partnerships? What does that look like in your mind if you were, again, you had to roll out an initiative yourself as a rural health leader?
Yeah, well, number one, if I was a hospital CEO, and most of them are doing this, I make darn
Yeah.
sure I'm best buds of the town newspaper, the local newspaper. Make sure you're telling your story. That's really,
Yeah.
really important. Number one. Number two, how do you communicate that in almost every county, the rural healthcare system, rural hospital is the largest employer?
Hmm.
Too often, I think small towns think, oh, well, this is our access to care. Yeah, that's important, but you're also the largest employer. So, as that, how does that hospital then be able to work with business leaders and community leaders, the county commission, to be able to say, okay, how do we improve our town? I think that type of recognition of a rural hospital as a community asset is something you've got to put foremost in people's minds.
Yeah. Well, I want to touch on something that you mentioned earlier, which is obviously it comes up in a conversation a lot. It already has today, but rural hospital closures, right? I mean, it's been a persistent concern over the past decade, but for longer than that, right? It maybe just has been heightened in recent years. But what trends are you seeing nationally right now as it relates to that?
Well, thank you for asking that because, wow, this is the question right now, and that's not in a good sense. I mentioned earlier that we've seen roughly 200 close since 2005. Brendan, last year we only had six rural hospitals close, which is amazing. I mean, it's horrible to say, but it is amazing. We only had six. We're into April when we're taping this right now, and we have not yet seen a rural hospital close in the United States. That's unheard of. We're staring down the barrel right now of weakening economic conditions. You're seeing the roll into, unless Congress acts, of as much as $155 billion in Medicaid cuts. And this is really a scary time for rural hospitals. It really is. And when is that proverbial financial rat moving through the snake going to get to a point where we're going to see it? And when it happens, it's going to really capture national attention.
Well, I mean, I mean, when a rural hospital closes, you already talked about how most of these hospitals are an economic driver. I mean, how do you articulate the ripple effects that happen that are created for the community beyond healthcare access when that happens to a rural hospital?
Yeah, we don't quantify that enough. People, when they hear it, like I mentioned, they originally think, well, that's a loss of access and
Yeah.
access point. But you're talking about all those employees in the facility that you're losing, the town's largest employer. Then you completely oftentimes forget about those businesses in the community that are integrated, whether you're talking something as like the town florist as well, local food service, other things that are on the periphery that are impacted by that. That's before you get to, I think, the real problem. That is, if when you lose that 24/7 ER access, you create a barrier for seniors living in that community. It just isn't safe without being 30 minutes to 24/7 ER. When a lot of these rural hospitals lose maternity care, that also becomes a barrier
Mm.
for young families coming in. So the data just shows when you lose a rural hospital, oftentimes the community ends up following. And that recognition of the community aspect, a community asset perspective of these hospitals, you just can't undersell.
Yeah. Well, you're talking about, OB access, right? And employers coming or not coming to a certain area. What have you seen those conversations like? I mean, what's the reality, right? If there's a economic development organization trying to bring in a new company to a rural area, what does that due diligence normally look like? And I mean, we always talk about healthcare, schools, are the two largest drivers of economic development in terms of new entities or growth or investment in growth, right? But I mean, I don't know how often you're involved or in those conversations, but how are rural health leaders best articulating their value prop when they get into those discussions with economic development, or when we think about it in that vein?
Yeah, so it better be front and center. At the federal level, we actually participate in a coalition called the Rebuild Rural Coalition. And
Okay.
this has more than 300 organizations: Farm Bureau, Farmers Union, National Rural Electric Cooperative, National Rural Education, all these different organizations across sector. And we have long served on the steering committee of this national endeavor because of the financial role these healthcare systems play in that, number one. Number two, you talk about this. I always like to see where um, big money pushes this to happen. And a story that's flown under the radar is the increasing importance that the U.S. Defense Department places on these small hospitals, because oftentimes these military bases are adjacent to
Mm.
rural
Yep.
communities, and it's interesting to see the Department of Defense then jump into HHS and the White House get involved and say, we need to address this rural hospital. It's about ready to close because we have to have that access to healthcare for this military base. So uh, it's not just about health. It is about the success and the viability of these communities and the industries that are located in rural areas.
Yeah. What do you see happen? I mean, and take me through to conclusion on that idea that you just described. So there's an Air Force base nearby, hospital, risk of closure down the road. Take me through to conclusion. Have you seen this real life example? I mean, it sounds like you have. I mean, what does that support look like for that hospital? They get involved, and all of a sudden it's a financial injection, or what? What?
Well, this is a very unique, and I'm blanking on the facility
No,
name
no.
off my head on this, but it's a good example where the Department of Defense reached out to HHS, and HHS then reached out to another agency, the Health Resources and Services Administration. And lo and behold, we actually partner with USDA to provide technical assistance to rural hospitals and revenue cycle management, billing operations. And so at the end of the day, after everyone got together, it ended up being the USDA funding technical assistance for this particular facility to come in and talk about, and again, how could they improve their finances, keep the doors open. And it ended up being a success story. They stayed open. And again, sometimes having an exterior voice come in to a new set of eyes on what you're doing and what can be improved
Right.
on makes all the difference in the world.
Yeah. Well, again, it just goes back to an earlier comment you made, whether it's external coming in or internal going out to learn, right? I mean, you learn some of these strategies by just being proactive.
Yeah.
So I want to talk about policy. I mean, you're involved in so much policy discussion, in which I think I'm not going off on a limb to say it's been a lot of negative press lately. But are there any particular policy or payment changes that you think could significantly reduce the risk of closures and support rural health that you've either seen been proposed recently or just ideas?
Yeah, well, let's start with this. Obviously, the easy one, and that would be I mentioned we have this transformation fund right now, and it's not to replace Medicaid cuts. It's supposed to be able to develop new paths for sustainability going in the future. Um, we're not going to see that tomorrow, but we are going to see the next 5 years. So it makes perfect sense for members of Congress now to delay these Medicaid cuts for rural facilities until we actually see these new paths going ahead. So I'm hopeful as we plow into these midterms, we'll see more and more movement on Capitol Hill from members of Congress say, hey, we need to delay these Medicaid cuts, um, certainly for rural facilities until we see some of the positive response from these things going on from the
Yeah.
transformation, number one. Number two, I do think, and we talked on it earlier, utilizing technology as a tool to help that certainly in freeing up time and more time to patients, you got to love that as well too. The workforce component of it, new approaches to making sure we're recruiting and retaining clinicians and staff in. I think that's a very positive approach as well, going ahead on that. Um, I am hopeful that working in collaboration with insurers and also of Capitol Hill, we can address some of these issues and concerns that we had with Medicare Advantage in particular, making sure we're having timely payments and getting paid, and eliminating these denial of cares as well too. And getting in the weeds, this will probably take a whole nother podcast for us, but Congress has a very valuable program, the 340B
Yep.
drug program, which is designed to keep the doors open on safety net providers.
Yep.
And we've been struggling with court cases and battling
Yep.
pharmaceutical companies for quite some time about ensuring this important tool goes ahead. I think
Yep.
there's a lot of things to be optimistic about at the end of the day.
Yeah. Well, I'd love to hit on that. 340B is something we talk about a lot with our clients in terms of domestic utilization. How can you harness 340B to your advantage? You're a covered entity, right? If you own your own pharmacy, there's a lot of innovation that can be there to support your population in a positive way. So the 340B program, it's become a major policy debate. You're talking about some lawsuits. Tell us about this program, why it's so important for rural hospitals. I think, a basic line there would be great. And then if you want to follow that up with the debate against, between big pharma and, HRSA, 340B, I'd love to understand what that climate looks like and what are the key points of the debate.
Yeah, let's start with this. And the irony in this is, whether it's the administration, even pharma or Capitol Hill, no one debates the importance of this particular program for rural hospitals. So there you go. But it's a national program, and so we worry about getting caught up in it. They're concerned about very large, very well-heeled healthcare entities that are making a lot of revenue off of this. And the question is, was that what it was intended for? But the messaging on this is just driving me insane. And let's just unpack that for a second.
Please.
Just for your listeners, this is the problem with being involved in health policy for 30 years. You were actually I was there. And Congress just thought they were so cute in creating this program because they didn't want to put the actual taxpayer dollars towards keeping the doors open on safety net providers. And they thought, hey, let's take it from the
Big pharma.
pharmaceutical company. We don't have to pay, they pay. Aren't we smart?
This
Well,
is
that's
great.
great. I didn't mind that. But then you flash forward 20 years, and now pharma is putting out commercials saying, can you believe it? They're not passing on these savings. No, that was never the point of
Right.
this program. This
Yeah.
was just merely a way for politicians not have to worry about paying for it. And that's just so incredibly frustrating. It makes providers look like the bad guys when that was never,
Yep.
ever intended. If you actually wanted discounted drugs, that's a whole different thing for the
Right.
patients. Now, that being said, a lot of rural facilities do. They do pass on part of that, but that's not what
Not
this
the
was
intent.
for.
Yeah.
And that is just there needs to be a textbook written on this particular policy issue because it just is crazy.
Well, it's a great soundbite for big pharma, right? They're not passing along the savings. That's what this was intended for. And when you talk to any hospital leader, uh, they'd say, well, we'd be hard pressed to refute that. our taking a part in some of these shared savings programs, again, it keeps the doors open. So what's more valuable to rural health, right? I mean, that,
Yeah, and I mean that's almost when you get back, the swing bed program was a congressional way to make sure that we can actually keep the doors, cost-based reimbursement
yeah,
for the critical access hospital program. Congress, and we mentioned this, every 2 years they come up with another cute way to try to make sure we keep access there. And oftentimes later on, as people leave and they move on to other careers, they forget why those programs were put in there in the first
yep.
place.
Yeah. Well, I want to talk about cost-based programs. I mean, critical access hospitals, that's a huge feather in their cap, right, in terms of sustainability and financial security. Have you seen legislation that has tried to expand that to, or been proposed to expand that to other rural health entities? Obviously, it's a cornerstone of CAHs, but oftentimes some of your larger rural hospitals, uh, who don't see the benefit of programs like that and others are the ones that kind of hurt the most financially. And so I'm kind of curious as we talk about policy, what else you're seeing in the fabric and the landscape in the last handful of years that might expand some of these programs.
Yeah, cost-based reimbursement has just been such an amazing, effective tool to keep access to care in these rural communities. It just has worked without a doubt. And because of that, we've seen it expand from the initial place up to psych and rehab beds in rural
Yep.
hospitals as well too. We've seen a call for it for home health as well too. It is a tool to keep the doors open. And that being said, man, federal policymakers hate it. They just always have hated it. They don't see it as being efficient.
Really?
And that just demonstrate a lack of understanding in a rural context. That being said, I still have hope. CMS had a demo in Pennsylvania a few years back looking at global budgeting. And I think you're going to see some of these maybe seep into some of these transformation programs that you'll see at the states put out. I love the concept of a global budgeting for a rural community. I don't know how it would work in an urban community, but that's where you look at what was the total cost of care in this
Yep.
area last 3 years. What's the average? Put a cost of living adjustment on it and just cut the check to that hospital and say, you do what you can to keep patients out. You're guaranteed to get this money. You try to improve the health of the community. I love that concept. And the CEOs in Pennsylvania that engaged in it loved it. It's a little bit scary because you're leaving that cost-based reimbursement. That's a tough sell to real CEOs. So I'm always careful on that. But nonetheless, it does get to that component of how do we pay hospital CEOs do what they started their job was, and that is to keep the community healthy and out of the ER room in the first place.
Yeah. Well, I mean, we're talking about reimbursement. I don't, you tell me. I mean, it's no secret that many of these, rural health facilities, I just want to use that blanket statement, just rural health, that reimbursement is usually your federal payers, right? And if you talk to most CEOs, they will tell you, uh, 100% of Medicare does not cover my cost of care. And when that's your largest payer, or Medicaid, which in some instances pays less, right? Um, where does that conversation fall flat at the federal level? I mean, when we talk about increases in reimbursement and trying to um, stimulate sustainability.
Yeah, the problem we're running, the federal is like, well, we're all moving to outpatient care. Well, well, I don't disagree with that. But to your point, it gets to the fabric of rural communities. It is not unusual for a rural hospital to see 70, 75% of their inpatient care, Medicare, Medicaid, IHS, VA. I mean, talk about a government-sponsored program. I mean, that's incredible to have that. And that is reversed when you look at urban based facilities. It's that private pay that is
Right.
the dominant one on that. So as that just means you have to have a good business partnership at the state and federal level with these rural providers. And it really is a matter of being a good business partner on that because the demographics of who's in these rural communities and who's showing up the door to these hospitals.
Yeah. I want to go back to 340B. We kind of jumped around to cost-based reimbursement and then
We
reimbursement in
did.
general.
Too much fun here.
Yeah, you're making me take a nonlinear approach to this discussion, which is great. I always love that. I mean, where do you see, so back to 340B, I mean, where do you see, there's a lot going on, but I mean, where do you see that policy discussion heading over the next few years? Where's your compass pointing if you had to guess?
Well, I'm optimistic. So take that with a grain of salt on this. But I will say this, when you look at University of North Carolina, their Sheps Research Center, they do a lot of analytical work on rural hospital finances. And it is amazing going through their research that it, almost every rural hospital that has had a positive margin is participating in the 340B program. It has made the difference between being in the black and being in the red. You cannot understate the importance and the value of this program to the operations of these rural facilities. That's just such a powerful data point and a selling point on that. Number one. Number two, like I said, we're getting hammered and getting the black eye on this. Oh, you're not passing on the savings. But let me be clear again, absolutely everyone involved recognizes the lifeline that 340B is in rural. And it's just of how do we parse, how do we make sure that we, if any reforms to the
Right.
system at all, do not adversely impact that. And I really believe that it's a long road, but I'm really believing that at the end of the day, we're going to maintain this as a lifeline for rural hospitals.
See, I see. So if I'm hearing you, you know, the big pharma um, legislators are, if they haven't already, are targeting the large systems who are benefiting when maybe that was never the intent. Am I saying that correctly? Maybe you know what I mean. You don't want to make that statement, but I'm curious if that's more or less the crux, right? I mean, and if everyone knows that, right? Is it just is it a lobbying issue? Is that just what it comes down to?
Brendan, that's the great thing of being CEO of the National Rural Health Association. I don't have to concern myself with urban issues. They can have that discussion, have at it. I don't
Yeah.
have to input on it. I don't have to observe on it. I just can focus in on what a great program this is for rural. Isn't that
Right.
wonderful?
It is. It is. Well, talking about rural, health being debated. I mean, rural health policy in particular. You're up in Washington, right? I mean, you're around policies being debated, maybe even behind closed doors, right? What arguments, when you think of it in that perspective, about rural hospitals surprise you the most?
Oh gosh, what arguments? What do I hear on Capitol Hill that surprises me the most? And well, we've already touched on a lot of it. Drives me nuts. Us too often, policymakers say, "What are we going to do about rural quality? How are we going to improve this?"
Right.
We don't do anything.
Misnomer.
That fallacy. Two, bad management. Gosh, that just drives me nuts. I mean, what I I always when a federal official says something like, "Oh, I'd love to see that data point." Well, I don't have that data. No, you don't, because it doesn't exist. It's just a trope that you use on that about bad policy. It's not on that. What I really am hammering, you started with this, is I love it when members of Congress, and I got Dr. Oz, when 2 months ago we were talking, and he led with this, that these rural facilities are innovation hubs. They are. And it's just basic organizational theory. In small organizations, you can try
Yep.
something new,
Yep.
and then if it doesn't work, you stop. In a large healthcare system, you've got blue ribbon panels, you got task force, you got it. By the time you talked it to death, you forgot about what you were trying to fix. And they recognize the fact that you can do so much innovation in a small organization. And so that really, that especially that I mentioned, both Secretary Kennedy and Dr. Oz, I mean, you listen to them and they are hammering away of this, of the, we're going to find out how to fix our health system starting in the rural context.
Wow. Well, I mean, technology, you mentioned earlier, technology's changing care delivery rapidly. So do you see that happening today, or is that something you see happening in the future where it starts at a rural hospital, it starts at a FQHC, right? We've been talking mostly about hospitals, but rural in a rural setting. I mean, is that happening today?
It's happening today. I mean, if
Yeah,
you think about telehealth, and I mean, rural America has driven telehealth. Let's be honest. Telehealth policy rules driven
sure.
it. NASA was important in that, but I'll be honest with you, and I think about this with the current NASA. What is more rural than space? I mean, that just is that is our future on that.
Yeah.
So between what is being driven on that and early adoption and trying of I think as well too, those two going tandem hand in hand, it uniquely places rural in the driver's seat of how we're going to be delivering healthcare going ahead.
Yeah. So what should rural hospitals, you say, focus on when they're evaluating new technologies so they can improve care, without adding unnecessary complexity?
Yeah, that's the key, right? How many times we've heard about that? Well, I got to tell you, I remember the fad of 10 years ago when at our conferences, all these robots were showing up and they were going to be going room to room. Really? Is that really going to? No, no, no. That's an example of where you just see technology running amok on that. Now, maybe they'll get there now in the future with Tesla, but we'll have to wait and see on that. It has to be appropriately priced, number one. It has to be able to fit into the current operations, number two. And it has to enhance your current abilities, not trying to replace what you should have. I think those are fundamental approaches that anyone should be looking for when it comes to rural.
Yeah. Well, when you talk to rural health hospital leaders across the country, just in general, I mean, technology aside, but I mean, what separates the organizations that are adapting successfully from those that are struggling? And I guess a follow up I'd have is, do you feel like the rural health transformation will only separate higher performing systems from laggards when it comes to adoption of new practices, new technology, et cetera?
Well, I certainly hope that's not the case. I certainly hope that's not the case
Yeah.
going. Time and again, there's been a lot written about leadership when it comes to rural. That is the success of a rural hospital. The most important predictor for that is the CEO and the leadership capacity on that. And collaboration. You just can't understate that. Being able to collaborate with a community health center to be able to utilize and leverage some of their payment policies and regulatory in bringing in clinicians. Being able to partner appropriately in an appropriate manner. I got to be very careful with that, with a large urban institute that might be able to bring in specialty care as well too on that. Um, Collaboration seems so easy and so straightforward that you would think everyone would be doing that. But it just apparently doesn't come easy.
Yeah. Well, looking ahead, as I've tried, we always want to look to the future, and I'm looking at you as somewhat of a crystal ball, right? Looking ahead 5 to 10 years, I mean, what gives you the most hope about the future of rural healthcare? And you've touched on some of this. You've touched on the innovation and kind of where you think things are heading. But if you had to encapsulate that, give it to me.
Yeah, the recognition, the growing recognition that local community healthcare as an access point reduces cost in the long run. I have, and I say that is just, I hear that being hammered home from the current administration, and you're going to hear this going ahead. This recognition of we just simply can't expect to life flight everyone out of rural America anytime that they need to
Right.
see a clinician on that. Technology is not going to totally replace this. You got to have that ER doc there from that time that you have that trauma case coming in. But I think at the end of the day, this recognition of the value, the importance of rural, number one. Number two, let's don't undersell. You look at the demographics on this. There's this thinking that rural America is just graying and moving away and dying away. The Census Department includes rural adjacent to urban is the fastest growing geographic area in the United States, number one. And over the last 5 years, rural has actually grown. It hasn't grown as fast as urban, but it's grown. So as we're having technology allow people to live where they want to and be able to remotely work, you're just going to see this trend continue. So
Yeah. Well, I would hope that that alone would be a policy spearhead to say, look, these communities are growing. It's not what you would think in the headlines, and so these all the more reason to support rural health, make it a priority because it's not a program, right? We can't just wish away some of these problems that exist with when you certainly when you think of financial models around rural health.
yeah, yep.
Yeah. Well, Alan, I've enjoyed this conversation. I mean, you've imparted some wisdom. I'd say, is there anything that we haven't touched on where you feel you'd love to kind of talk about your experience from your position with our listeners?
Yeah, I just kind of wrap this one up, and I mean this kind of is something that I know you've seen, Brendan, on this. Our organization, we work so hard. What we do is we identify the best practices, we share those best practices, we hope for replication. From time to time, we see that there's policy or regulation that prohibits those best practices. That's when we jump in and we lobby. But this whole work, it takes years. We've been fighting this 340B now for way too long. Medicaid, we're going to be fighting this. At the end of the day, one thing I want to share is identifying great business solutions that are priced appropriately and understand rural communities to partner with rural facilities. That needs to be highlighted more. At our conferences, we really drive home the, hey, we've got a vendor exhibit hall over here. You can improve your healthcare tomorrow with this. And it gets back to this underlying theme we've talked about this whole time, and that is collaboration. How do you find good partners to work with? How do you be able to work with good partners? And how do you expand outside your sector to increase access to care and healthcare quality? I think at the end of the day, that's the secret sauce.
Well, and at the end of the day, is that one good reason for you know members, hospital leaders to engage with your organization or with their state rural health organization? I guess I haven't asked that, and it wasn't something I'd planned to ask, but talk a little bit about that. Talk about what you see, rural health leaders getting out of a really great relationship with your organization and their state organizations.
Yeah, and that's a good point to bring up. We're not like a normal trade organization. We're a geographic-based organization, which is great because we're one of the few organizations that I am constantly trying to promote my members to join and be active in the Missouri Hospital Association and join and be active in the American Hospital Association because I want my rural guys and gals in there touting the benefit of rural. I want them within those organizations. Now, if you are interested in our organization, it's so easy. Just type the words rural health in Google, Yahoo, Bing. Our association is always one of the first ones that pop up. And you can track what's happening both at the state and federal level. What's the new innovations you're seeing in rural? It's just a great way to stay involved and stay active, make your voice heard.
Yeah. Well, what's as we wrap up, I mean, I love asking this question. What's one mindset shift you believe rural healthcare leadership needs right now? And then really, what's one action those leaders can take this month?
Oh gosh, I've got so many. How do you pick one to make sure it's the right one to go with on that?
You give me two. We've got time.
Let's tell your story. It's as simple as that. And you and I, we've covered this. Um, Policymakers need to hear an authentic story of what you're seeing in your small town. They don't need to hear what they're hearing from the sound bites or what they may have thought in the back of their mind. Uh, Take the opportunity as a leader in your community to reach out and talk to policymakers and say, here's what's happening in our community. Here's what's being talked about at the federal level. Here's how I see these two things interconnecting. Bringing that down to the local makes all the difference in the world. It is shocking how much a difference one person can actually make.
Wow. Well, Alan, I really appreciate your time, and I can foresee us. You alluded to it. We could have a podcast just on 340B alone, and I might take you up on that for a call it a volume two. But this has been a great conversation, and I really appreciate you
Been fun.
coming on our program.
Yeah, I really appreciate the opportunity. Thank you for talking about rural. It's great to catch up with you, and I'll be happy to come back anytime.
Thanks, Alan.